that you will understand what I'm speaking about. So when we look at the nerve injuries of the human, nerve injuries in the lower limb are less frequent than injuries in the superior limb. But when we look at these numbers from the University of Louisiana, we can see that 30% of injuries in the peripheral nerve system are located in the lower limb. But almost a half of the lesions of the nerves of the inferior limb are lesions of the sciatic nerve. So this is a very important nerve in the human anatomy. And also, the sciatic nerve is the longest and widest nerve in the body. It originates in the intrapelvic region from the sacral plexus. It goes in the gluteal region and travels in the posterior aspect of the thigh, ending in the popliteal foci. And in this long trajectory, the nerves have some anatomical variations. So we will review the surgical anatomy of the nerve that is formed by union of L5 nerve through S3 nerves. It forms as I said, in the intrapelvic region and runs through gluteal and posterior tight region, ending at the popliteal foci by bifurcation in the two terminal branches, named the tibial nerve and peroneal nerve. But there is an important detail. This is an anatomical specimen of our cases. The sciatic nerve is not a nerve, but is two nerves involved by the same epineuron bundle. So we can see here an histological specimen of the sciatic nerve with the two components, the tibial and the peroneal nerve. And we can see here that there is not only a nerve, but two nerves running together. This is important because it is the origin of the great majority of variations of the nerve. This is a very beautiful drawing of my favorite book about peripheral nerves anatomy, the Lasorte's book. We can see here the formation of the sciatic nerve. This is L5 nerve. It receives a contribution of L4 to form the lumbosacral trunk, and the lumbosacral trunk forms the sciatic nerve with S1, S2, and S3. We can see the nerves that origin the sciatic nerves here, located in the posterior part of the pelvis, and here in the lateral part of the pelvis, running through the sciatic notch. So this part of the nerves take relationships with intrapelvic contained. So the rectum is located here, and here the nerve is located in retrorectal position and pararectal position. This is an anatomical specimen when we can see here the external iliac vessels, the internal iliac vessels, the obturator bundle with the nerve, the vein, and the artery, and we cannot see here the nerve because it's hidden by the branches of the internal iliac vessels. So this part of the specimen is this part of the drawing. But this is important because we need to remember that if we have a patient with sciatic pain without lumbar pain, the patient can have an intrapelvic compression of the sciatic nerve or the nerves that form the sciatic nerve. So I will show you two cases. This is an anterior sacral meningocele, and this is the sacral bone and the nerves that form the sciatic nerve, and this huge mass was compressing the sciatic nerve in the intrapelvic portion bilaterally. This is another case that we operate on in Ecuador with my friend Shimiachi. This is a tumor, an Ewing sarcoma. This is a rare, very strange case. It's an extraosseous Ewing sarcoma located here in the pararectal space and compressing the left sciatic nerve, causing a very important sciatic pain. And we operate on this patient, obviously, with coloproctal surgeon, and with Shimiachi, we perform the resection of this mass, preserving the lumbosacral plexus and obviously the origin of the sciatic nerve. After this origin in the intrapelvic region and this relationship with retrorectal and pararectal spaces, the nerve runs through the sciatic notch and goes to the gluteal region. And we can see an osseous specimen with the landmarks, the anatomic landmarks that we will use to locate the sciatic nerve. So we can see here the coccyx, the ischial tuberosity, and the great trochanter of the femur. And the nerve runs from the sciatic notch to this canal formed by the ischial tuberosity and the great trochanter. So if we trace a line in the middle point between these two osseous structures through the sciatic notch, we can see the trajectory of the nerve. So if we can locate by palpation, the coccyx is located more medially, but here is the location of the coccyx, the ischial tuberosity, the great trochanter, and in the midpoint or more close to the ischial tuberosity, we can locate the sciatic nerve. So the anatomical specimen, and we will perform a dissection of the region step by step. Here we can see the skin. This is not a cadaveric specimen, of course, and this is a cadaveric specimen. We take out the skin. We can see here the fibers of the gluteus maximus muscle, and here the hamstring muscles. So we will cut here the gluteus maximus muscle here, and we will retract laterally the gluteus maximus to see the deep compartment of the gluteal region. So here we cut the fibers of the gluteus maximus muscle, and we can see here the structures of the deep compartment of the gluteal region. So the ischium or ischial tuberosity here, the sacrotuberous ligament here, the pyramidal muscle here, and we can observe here and here the neurovascular bundles to gluteus maximus muscle, and here the sciatic nerve in the infrapyramidal compartment. When we cut the sacrotuberal ligament, we can see sciatic nerve and pudendal nerve here. So in this picture, we can understand that we can approach by the same approach the proximal part of the sciatic nerve and the pudendal nerve. We can see here the pyramidal muscle, a bundle to the gluteus maximus muscle, and here again another bundle, neural bundle to the gluteus maximus muscle. So we can understand here the anatomical basis of pyramidal syndrome. This is the pyramidal muscle, this is the sciatic nerve, and the nerve can be compressed here by this muscle. Another dissection, or a more detailed dissection with the ischial tuberosity, sacrotuberal ligament here, and we cut this ligament, the pudendal nerve, the sciatic nerve, pyramidal muscle here, and the nerves to the gluteal maximus muscle. Again, and again, with the superficial structures, the deep structures, and the osseous landmarks to locate the nerve in the gluteal region. So, in this proximal part of the nerve, look at this. This is a paper that we are writing with Carlos, Mariano, Javi Robla, and Deborah Garozzo. We have 34 cases of sciatic nerve injuries and approaches. And to the proximal part of the sciatic nerve, we perform 70 approaches. See, and look at the causes of the approaches. More than a half of cases, more than a half, are related to iatrogenic injuries, related to gluteal region injections, or hip replacement surgeries, and closed hip trauma. And to this part of the sciatic nerve, we can use 3 approaches: the classic or Stucky approach, and the transgluteal and subgluteal approaches. These 2 approaches are less invasive and more cosmetic than the classic Stucky approach. We will see the 3 approaches shortly, because this is a webinar about anatomy. And the classic or Stucky approach gives us a very, very good exposure of all of the trajectory of the nerve in the gluteal region, and is very good for oncological surgery, but it's not a cosmetic approach, and is a huge approach that needs the section of the gluteus maximus fiber, and is associated with a great amount of pain and atrophy of the fibers of the muscle. This is a picture taken from the doctoral thesis of my dear friend Mariano Sokolowski, and we can see here the incision in the gluteal region. It's a huge incision. It's not cosmetic. The sectioning of the fibers of the gluteus maximus muscle, the retraction, and the exposure of the proximal part of the sciatic nerve. This is not a case of my experience. This is taken from this book, and we can see the huge incision, but also the huge exposure of the proximal part of the nerve. So, as I said, this is a very good approach to oncological surgery when we need to resect a great amount of tissues of the region. But as we can see here, it demands a great dissection and cutting of the fibers of the muscle with bad aesthetic results, and also with a lot of pain in the region and functional alterations in the gluteus maximus muscle. So in the last years, there is a great development or less invasive approaches. So the transgluteal approach is a good alternative to the classic approach, because it uses a small incision, have better cosmetic results. It doesn't cut the muscle, it spreads the muscle fibers. We only cut the superficial aponeurosis of the muscle and preserve the muscle fibers. And because of this, it's associated with less pain and a short time to return to work, and the patient can walk maybe the same day of the surgery, if not have a great amount of pain. This is the incision we use for the transgluteal approach, taken from this paper of our friend Mariano. And I will show you a short case of a gunshot injury in the proximal part of the nerve. We can use for this approach the Stucky approach, but we prefer to use the transgluteal approach. And look at the exposure that we have of the sciatic nerve. By the transgluteal approach, we can expose 10 centimeters of the sciatic nerve, and here the lesion in one part of the sciatic nerve, we repair this with graft using a small incision. Subgluteal approach is also less invasive and cosmetic than the Stuckey approach, but have a problem because it gives us a limited exposure of the nerve. For example, it don't give access to the proximal part of the nerve. For example, if we need to treat a pyramidal syndrome patient or a pudendal syndrome patient, we don't use subgluteal approach. We need to use the transgluteal approach. This approach gives us exposure of the transition of the nerve in the gluteal to the posterior tight region. So the incision is located here in the subgluteal fold. For this reason, it's very anatomical and very cosmetic. We can associate the subgluteal approach with a midline incision in the posterior tight region if it's necessary, and it gives us more exposure or a great amount of exposure of the transition between the gluteal and posterior tight region. This is the gluteal nerve fibers. We retract proximally the fibers of the muscle. We can see here the hamstring muscles. The hamstring muscles are retracted medially. The gluteal maximus fibers are retracted cranially. And this is the exposure of the sciatic nerve in the transition between the gluteal region and the posterior tight region. And we can assess this part of the nerve. It was a gunshot injury, and we can repair with graft this part of the nerve. This is the cosmetic result. It's very good. And in our experience of our group, of Mariano, Javi, Carlos, and Deborah, we perform the classic or Stuckey approach only in 3 cases. We perform the subgluteal approach in 40 cases, and we use very frequently the transgluteal approach in 53 cases. I use, in one case, the combination of transgluteal and subgluteal approach for a girl with a sciatic nerve injury. So I perform 2 incisions, one here and one here, and I work through the muscle here without cutting the fibers, and behind the muscle here, and I expose all of the trajectory of the nerve without using this very huge approach in a girl. I think they have 18 years old, and we preserve the cosmetic of the gluteal region and all of the fibers of the gluteus maximus muscle. So after running in the gluteal region, the nerves goes to the posterior tight region. And here, the nerve is very easy to locate, and the relationships are very easy to remember, because the nerve is located in the midline between the hamstring muscles, biceps femoris laterally, semitendinous and semimembranous medially. This is an anatomical dissection of the sciatic nerve in the posterior tight region. Here we can see the hamstring muscles. Here, the biceps femoris. Here, semitendinous and semimembranous. And here, the sciatic nerve, with the ending of the nerve by bifurcation in the 2 terminal branches, the tibial nerves and the popliteal nerve. And pay attention to this. Here is the nerve, and here the hamstring muscle nerves originating in the sciatic nerve. So when we here we can see a detailed view of the same thing. When we dissect the sciatic nerve, it's better to dissect in the posterior aspect of the nerve, respecting the medial and lateral aspect of the nerve, not to damage these branches to the hamstring muscles. But this is a very interesting article about Bretonnier and collaborators. They made a map of the branches of the sciatic nerve to the hamstring muscles. That is a very important guide to treat patients with spasticity of the posterior hamstring muscles. And they use the great trochanter as an anatomical landmark, and they trace a line in the great trochanter of the femur, and they found that most of the time the hamstring nerves or the nerves to the hamstring muscles are located 2 to 3 centimeters below this line. But the nerves can be located up to 5 centimeters above and 10 centimeters below the great trochanter. So they stated that an incision located 5 centimeters above and 10 centimeters below the line of the great trochanter give us access to the branches of the hamstring muscles. This is a very interesting article, anatomical article, that give us a map to find the branches to these muscles. The nerve ends by bifurcation of the popliteal fossae in the tibial nerve, that is the dorsal flexor of the foot, and the peroneal nerve, that is the this is and the peroneal nerve. This is not correct. Is the tibial nerve is the tibial nerve is the dorsal flexor, and the peroneal nerve is the plantar flexor. Sorry. We can see here the end of the nerve in the two terminal branches, the plantar nerve, the tibial nerve, sorry, that is a plantar flexor, and the peroneal nerve, that is a dorsal flexor of the foot. And if we see that in the posterior tight region, the nerves have no very important relationships, here in the popliteal fossae, the nerve have very important relationships. The nerve is in relation with the vein and the popliteal artery in an arrangement called the Farabeuf stair in the French literature, because we can see a stair in the arrangement of structures from medial and deep to lateral and superficial, the artery, the vein, and the nerve. We can see here in this anatomical drawing the artery, the vein, and the nerve, and here the sciatic nerve, the tibial branch, the peroneal branch, here the vein, here the artery. Look the close relationship of the ending of the nerve with the popliteal vein here and the popliteal artery here. So in this region, in the popliteal fossae, we must to dissect very, very carefully not to damage the popliteal vein. In the posterior tight region, we have also 65 patients and we performed 69 approaches, because in some patients we made combination of approaches. And look the pathology that we have here, more tumors and more gunshot wounds. And I will show you just a case. This is the midline incision in the posterior tight region. It was a gunshot wound affecting the posterior tight region and the popliteal fossae branches. Here we have the posterior hamstring muscles, and here the canal. Here we identify the nerve. We dissect all of the fibrosis, and we can see here the nerve. And the repair of the nerve with graft here in the transition between the posterior tight region and the popliteal fossae region. So, in the end, I will speak shortly about some anatomical variations. For example, when I said that the nerve is composed by two nerves from the origin, and this nerve separate from each other in different parts of the inferior limb. The classical bifurcation of the nerve in the popliteal fossae, we can see this in 3 of 4 cases. We can see the bifurcation in the posterior tight region in 11% of cases, and in the gluteal region, look, as the case I showed you in the beginning of the lecture, 4 to 10% of cases, and in 2 to 10% of cases, the nerve doesn't exist. What we have is the peroneal nerve and the tibial nerve separated in the beginning. We don't have a sciatic nerve as we know. This is an interesting cases taken from these 2 articles. We can see here the pyramidal muscle with 2 bodies here, and look at this. We have the tibial component originated or emerging from the intrapelvic part through the gluteal region, located below the pyramidal muscle, and the common peroneal component running through the muscle. And in this case, we can see the pyramidal muscle, as we know, not with 2 bodies, but with only 1 body. Here, the tibial nerve running in the classical position, and here, the common peroneal part of the nerve running above the pyramidal muscle, and they unite here to form the sciatic nerve. In some cases, these 2 nerves goes separately in all of the course. So we can find a transpyramidal course of the nerve or one of the branches in 4% of cases, and the nerve located above the pyramidal muscle in less than 1% of the cases. So these anatomical variations are predisposing factors to the nerve to be compressed partially or completely by the pyramidal muscle in the gluteal region. So thank you very much for your attention and patience. And I'm sorry because English is not my natural language, so I think I made a lot of mistakes. So I'm sorry, but it was really an honor to be here and to speak to you.
Thank you, Fernando, for this talk. Yeah, I'm ready. Thank you, Fernando, for this talk. For the participants, if anyone wants to ask anything to Fernando, you can use the chat or you can raise your hand for any questions.
Carlos?
Okay. Yes. Marian, how are you?
Carlos, do you hear me?
Yes, we can hear you. Yes, we can hear you, Marian.
Okay, thank you very much. I want to say, okay, thank you very much. I am really delighted to hear Fernando. His talk is wonderful, and in terms of anatomical approaches, it's very useful for all of us. My question would go to the piriformis syndrome. As Fernando mentioned, the anatomical component of this syndrome in his talk. Fernando, what is your experience, because you show very interesting cases on traumatic and also on tumor surgery. What about nerve compressions at this part, the piriformis syndrome? Can you very shortly give your experience on this topic? Thank you very much. Thank you.
Yes, Mariano, you are my friend. You are not an enemy. No, as we usually talked, the sciatic nerve is a very huge nerve, and the pyramidal muscle is a very small muscle. So I have not a great experience because I don't have a great amount of cases of pyramidal syndrome. I think in the experience that we publish, but we don't publish yet, but we are preparing the paper. If I don't remember, the number of cases of approaches to pyramidal syndrome were 7 cases in all of the series. In my personal experience, I approach the sciatic nerve for pyramidal syndrome just in 2 cases. And I have very great results with the 2 cases because I select these 2 patients with a lot of patience, sorry, and really one of the cases, a woman that I operate recently have a very fibrous band, a very tight fibrous band in the pyramidal muscle, and also a varicose gluteal vein compressing the nerve. And really, when we cut the fibers of the muscle, and I need to ligate the varicose vein, the patient really have a release of the pain. She lived with a great pain for years, and really I have a very good result with this case. And also I recently operated on men with a pyramidal syndrome and also have a good result. But I think pyramidal syndrome is much frequent that the people think. I think that your experience is similar. And can we talk? You can talk to us about your experience.
Marianne?
Carlos?
Yes, no, indeed.
No, I completely agree with you. Yes, can you hear me?
Yes.
Can you hear me?
We can hear you.
Oh, yeah, there's a problem. That's why there is a short delay. Yeah, okay. The thing is that I completely agree with you, dear Fernando. I think that the reason why we don't have too much experience in this syndrome is that is because we don't really believe this is a frequent situation, the nerve compression, and that's why the experience is very limited. And yes, in some cases, probably after trauma, secondary fibrosis of the piriformis muscle, that could explain some of the symptoms. And this, in fact, is not a real nerve compression or an idiopathic nerve compression, but it's rather a nerve trauma. I completely agree, and I thank you very much for your answer and for your excellent exposure.
Thank you very much, Mariano.
Yes, exactly. Thank you, Fernando. We have a couple of questions from Daniel Rajesh. His question is for you, Fernando, which nerve graft do you use for reconstruction?
Sural nerve.
Okay, yes. Yes, and this nerve, because it's a nerve that usually meets all the features of an ideal graft, no? A nerve easy of being approached, with providing the best support, anatomical, biological, and chemical support for nerve reconstruction. No needs of immunosuppressive management after the use of the graft, and with an expendable function. So sural nerve usually is the nerve that we as nerve surgeons use for almost all the cases. Okay, there are some exceptions, but this is the nerve used most frequently.
Yes. Is the ideal donor.
The ideal donor, exactly. So, Elena, okay, Elena Dabella from Napoli. Hello. Thanks, Fernando, for the great lecture. I have one patient operated on at another center for meralgia paresthetica 8 months ago. Sensitive symptoms improved, but local pain did not. What do you suggest? Revision surgery, observation? Okay, so this is a question apart from the topic, but Fernando has a huge experience in the management of meralgia paresthetica. So I think we can do a parenthesis
Yes.
to answer this question, Fernando.
Hi, Elena, thank you very much for your question. I think if the patient have local pain, I will initially manage the patient with local infiltration with anesthetic and corticoids first. And if the patient doesn't gives better, maybe revision surgery, but I don't operate on so easily when the patient have just local pain, because if sensitive symptoms, sorry, are better, I think the surgeon makes a good decompression. So again, I will perform 1 or 2 infiltrations in the pain area, and if the patient doesn't goes better, maybe I will recommend a revision surgery, but not at the first intention.
Okay, thank you very much, Fernando. And now one more question from Ibrahim. Fernando, could you share with us your experience after injection? I mean, injuries of sciatic nerve after injection, okay? In
Yes.
terms of your experience regarding the surgical management.
Okay. I think um, we can answer this question, maybe you, Mariano, or me, because in Uruguay, we don't have, unfortunately, a great amount of injuries by injection, but iatrogenic injuries of the peripheral nerve surgery are half of injuries, and the injections in the gluteal region or arthroplasty or hip arthroplasty are very frequent. In my experience, and Mariano can tell us about his experience, we only perform a neurolysis of the nerve by transgluteal approach, and it gives a great release of the pain in the majority of patients. I don't know, Carlos, if you have a similar experience. I don't operate on rapidly. I wait 2 months, and if the patient doesn't goes better, I operate on and made a neurolysis by the transgluteal approach. Your opinion, Carlos, Mariano?
Yes, indeed. I don't have a huge experience. I mean, in terms of number of cases
Okay.
for the management of injection injuries, but I think one of the most important issues in this topic specifically is the you need to consider some facts regarding the post-injection injury. No, I mean you may have 2 types of injuries: a mechanical injury by the needle, okay, and a toxic injury by the substance that is injected. So probably with this condition, the surgical timing should be selected very well in terms of what is the ideal time. I mean, this is not the same surgical timing by example, for than for the a traumatic injury of other nature. And usually, in my small experience with this topic, I only needed to decompress the nerve or neuralize the nerve. So. Another important fact in post-injection injuries are the prevention. No, education regarding what is the ideal site for for the application of the injection. I think is paramount. As you know, thinner patients have an increased risk of this condition.
Or kids.
Or kids, exactly. Okay. Okay, another question from Ibrahim.
Yes, I may
Ah,
do you hear me?
yes.
Uh, um, I'm
Now,
sorry, there is a big delay, that's why 10 seconds. But I want to point out also regarding Carlitos' answer that the the use of ultrasound and more specifically MRI is mandatory in this type of injuries because you can really locate the place of the injection and then you can do a good understanding of the type of injury. So you can see if there is a fibrotic tissue around the nerve, compressing the nerve, perhaps the cause of the pain will solve after the surgery and after the neurolysis. But if you have other type of injury, no. So I would also insist in the use of MRI after this type of injury, not only as a location for your surgery, but also as a way to predict the result of your neurolysis. Thank you very much.
thank you, Mariana, for your comment. One more question from Ibrahim. Fernando, any experience with nerve transfers in sciatic nerve injuries?
No, transfers, no. I have no experience. I just have experience in graft repair, but not in transfers. Or I think I have only one case. I remember that I made a transfer but not in the sciatic nerve, but in distal branches, trying to have a return of the sensitivity in the plantar part of the foot. I made, if I don't remember, don't remember it. I made a sural nerve to posterior tibial nerve transfer in a patient, trying to gain or regain the sensitivity of the plantar part of the foot. Just one case.
Thank you, Fernando. Uh, I have one question for you, Fernando, and now moving to traumatic injuries. And given the surgical results after peroneal nerve reconstruction, what is your opinion regarding the very proximal injuries of sciatic nerve involving both divisions? Your strategy, I mean.
Wait, my strategy is to try to repair proximally the nerve and to wait, because in my experience, a lot of traumatic injuries or iatrogenic injuries related to hip replacement have, for example, a great deficit, but they improve in time. So my strategy is wait to perform an electrical study and wait 6 months. If I don't have a good result of there is a clear injury in the nerve, I try to repair with graft and wait, because I am interested in hear your opinion and Mariano's opinion, but distal transfers don't go very good in the inferior limb. What my strategy is to wait, and as we all know, tibial nerves goes better than peroneal nerve. And if we have a good result or a good recuperation of the tibial part of the sciatic nerve, I try to perform tendon transfers to regain movement of the dorsal flexion. It is clear?
Yes. Sure. Thanks for your answer, and I think the same in terms of try to reconstruct both divisions, because usually the tibial division
Goes better.
goes better, exactly, and after many months you can do
Regain some function.
any attempt to try a tendon transfer. Um, okay. A question from Olger Alarcon. Hello, use of electromyography to follow the reparation nerve.
This is a very debatable topic. Yes, in some cases, yes, but I prefer to follow clinically because electrical study, electromyography can be useful in some cases because the electromyography can detect function. I think I again I am interested in hear your opinion, Carlos, but electromyography can detect muscular activity 1 month or 1 month and a half earlier than we can detect clinical movement. So in some cases is useful, but I really don't use as a routine the electromyography to follow my patients. I really use clinical examination and I select the patients that I will ask for an electromyography.
I agree with you, Fernando. And sometimes we need to adapt the resources to the environment and the country. By example, here in Mexico, I'm sure that electrodiagnosis, or specifically electromyography, provides a very useful information after nerve reconstruction. But unfortunately, here in Mexico, this type of study is expensive and is also painful. So I used to prefer the clinical following of the patient after a reconstruction. But there are some occasions in where probably the expected recovery of the nerve after a reconstruction is not running well. So in these cases, maybe the information provided by the electromyography could be very useful in terms of what we need to expect in a delayed fashion of recovery. Okay. No more questions. So we are almost on time. So if there are no more questions or comments from the participants, I'm reading the chat. Okay. So I think we can finish this webinar. And thank you very much, Fernando, for your wonderful presentation with wonderful pictures about the anatomical dissections. So, bye-bye.
Okay, thank you very much, Carlos. Thank you very much, Mariano, for the invitation. It was really an honor. We are great friends, but I have appreciation to you and Mariano, not just because we are friends, because you are very great surgeons of peripheral nerves, and you represent in a very good fashion the Latin American neurosurgery. So thank you, and thank you also to Francisco Luna, our friend from Chile, for his assistance to this webinar. Thank you all.
Okay, bye-bye.
Bye.
Bye, Francisco.